stand up. We're going to bless him.
Father in heaven, we thank you, Lord, for bringing us this evening, yet for this presentation on health. May we learn something from this program this evening and be blessed from the presentation. Lord, we thank you again for this evening, for everyone that is here. In Jesus' name we pray. This evening is a very special evening. All through this month of September, we've been focusing on health. And as the jingle says, we care about your health. It gives me great pleasure in introducing to you Miss Elizabeth Richard. She will introduce our speaker and presenter for this evening. Sister Richard, it's all yours.
Good evening, everyone. It's a pleasure to be a part of this evening's program. As Brother Jory said, we work as a team here, and it is my privilege and pleasure to have with us a very distinguished professional. Her name is Dr. Leila Jerome Clay. Dr. Clay is the director of the Comprehensive Sickle Cell Disease Program at Johns Hopkins All Children's Hospital, and also assistant professor of pediatric section of hematology at the Johns Hopkins Hospital School of Medicine. She is the associate director of the program for health equity research. Dr. Clay treats children, adolescents, and young adults with rare blood disorders such as sickle cell disease. She plays the role of a physician navigator in transitioning adolescent care to adult care. Dr. Clay has established her research in sickle cell disease, where she studied the mechanic contribution of vitamin D deficiency and its effects of disease manifestation of sickle cell disease, as well as bone diseases. Her primary professional objective is to translate her clinical research to the field. She remains focused in improving the care of the adult and young adolescent population in regards to sickle cell. So this evening, without further ado, Dr. Clay, we welcome you as you speak on the topic sickle cell disease. Thank you.
I want to thank you all, and thank you, Elizabeth, for this wonderful introduction, and thank you all for joining us this evening. And really thanks for the invitation to be able to talk about sickle cell disease, which really this month is Sickle Cell Awareness Month. So it's a pleasure to be here this evening with you all. So today I want to do an overview, and we'll talk a little bit about both. I did want to put my disclosures, which really don't apply to this presentation, but just to disclose them. So before we get started, I wanted to first talk to you about what is hemoglobin. Hemoglobin is really what this whole thing is about, because sickle cell and sickle cell disease is a condition that affects the hemoglobin or the red cells in our body. So when we look at the hemoglobin, we have to understand that everything that we have, every gene that we get, we usually get them from two of our parents, right? Genes are basically the codes that help build the body. And when two people come together, they share the genes, and you're able to really have someone with different patterns. So for example, the eye color is determined by a set of genes from the birth parents. So another set of genes that we're going to focus on this evening is the red cell. So the red cell, with its gene, the gene that helps make it is called hemoglobin gene. And it's really named after the hemoglobin protein that is in the red cell that help carry oxygen throughout the body. And the reason this is very important is that it will show you why some of the things we see in the disease, sickle cell disease, all go back to this little molecule called the hemoglobin molecule. So where does this all originate from, right? And everyone always wonder, well, why is it that, as African American, why do we have sickle cell disease more than others? When we talk about going back to Africa, so if you look up there, there's a map of the continent of Africa there. In the equatorial African, where the region of malaria was actually very rampant, there was actually an incidence of sickle cell disease, and it was its highest there. And what's happened is that within the hemoglobin gene, there was a mutation that occurred. With that mutation, it actually led to having sickle cell gene, which basically caused independent mutational events, not only in Africa, but also in Saudi Arabia, as well as India, which is highlighted in red above. One of the trailblazers of this was Dr. Charles Whitten, who actually discovered a lot of those things and how it goes back to Africa, and also push for sickle cell awareness and pioneering the efforts to really understand sickle cell disease. So this slide just really kind of helps us look again at where that hemoglobin mutation comes from. So again, the malaria region of Africa, Asia were really components of that. And you could see here the different types of hemoglobins that were mutated, right? So the sickle hemoglobin is a mutation that occurs that creates that sickle gene. The hemoglobin C is a different type of mutation. There's also hemoglobin D, which is often seen in India, and then also hemoglobin E, which we see more often in Southeast Asian countries. So there are a lot of and there are others. So I'm just naming the most common ones here. There are others. So when we look at that hemoglobin, what does it actually look like deep inside? So when two parents come together, everyone has what we call 2 alpha globin gene and 2 beta globin gene. When those genes come together, they actually make a hemoglobin. When you have a normal hemoglobin A is when you have those 4 genes come together. When you have a hemoglobin S, because of the mutation that occurs, those cells can look like an alpha beta globin gene. However, it will not be stable under stress. So it actually polymerizes or makes this shape of a half moon, or what we refer to as sickle cell. So what is really sickle cell, right? Sickle cell was not really discovered in this country, in the United States, till 1910. Now we do know for a fact that people in Africa has had symptoms of what we now call sickle cell. However, it wasn't really called sickle cell till the 1910 in the United States. We had a lot of African names for it back then. But people were experiencing sickle cell back before 1910. So in 1904, there was a young man from Grenada who actually was in school. He was a dental student who was in school, and with him, his blood was examined by this teacher called Ernest Edward. And Ernest Edward actually discovered that these cells were funny shaped. And his boss, James Henrik, who actually gets a lot of the benefits of what sickle cell is, was able to write a paper that was describing what they call this peculiar elongated sickle red shaped cell that causes sickle anemia. But I always like to remind you all that Clement Noel is really that 20-year-old dental student whose blood was used to discover sickle cell. So from 1910, we do now know that sickle cell disease is the most common inherited blood disorder in the world. It has what we call this autosomal recessive inheritance. And that's what I describe when I say two parents carry the gene. That's what causes the inheritance. In the US by itself, Black Americans, 1 in 365 are born with what we call SS. 1 in 13 are born with the S trait or S carrier, meaning one parent gives the S, the other gives the hemoglobin A. 1 in 50 have C, and 1 in 100 has what we call beta thalassemia. And of course, the reminder is that Hispanic, Southeast Asian, Southern European, and Middle Eastern people can also have sickle cell disease, as depicted here in this slide of the world. And as you could see, the prevalence of sickle cell is around 2%, where the US has around 110 people affected by the disease, the same as India. And in Africa alone, we have around 2 million people living with sickle cell disease, with Nigeria, Congo, and Tanzania being the largest of the population. I wanted to show you what the US really looked like, and I think it's important to note that as you look at the United States, the orange really depicts the increased frequency of sickle cell disease, with the deepest orange being that those states have more than 7,000 patients living with the disease. In the southeastern region of the United States, Florida is the highest, followed by Georgia. So we live in a state where almost 9,000 patients live with sickle cell disease. So, of course, we get sickle cell disease from what? From two parents carrying the sickle cell trait. So what is sickle cell trait then? Sickle cell trait is really when you have basically half sickle cells and half normal cells. The red cells are usually round, circular, and disc. And people with sickle cell trait, they definitely just have the one gene from a parent with the sickling hemoglobin and the other gene of a normal hemoglobin or hemoglobin A. We do know that people with sickle cell trait rarely have symptoms, right? Because they have that normal hemoglobin, they are protected. So they do have the abnormal hemoglobin as well, but unless they are under extreme or intense exposures, like intense exercise or even high altitude, will they actually be able to sickle enough that they're no longer protected. And the problem is that when you're sickling, the effects of the oxygen carrying capacity is decreased, which is what causes the complication. People with sickle cell trait can also have hematuria, which is basically when you can have blood in your urine, and they tend to be at a high risk of a red cell carcinoma called kidney carcinoma or cancer called red cell carcinoma. So those are some of the effects of sickle cell trait. But when we talk about sickle cell trait, though, they don't usually have symptoms. So please remember that, because they have that normal gene. So this picture kind of shows you what a person with sickle cell trait can look like, right? So in their body, they'll have those normal red cells, which are those nicely biconcave, or I like to call them donut shape, because if you look closely, they kind of look like little donuts. Mixing with those sickle cells that kind of look like a half moon or a banana shape, I often tell the little kids, or a sickle, right? Which is an apparatus used usually to do the ground. So Now we talk about the genetics. So when you have the trait, meaning, so these two parents have the trait, meaning they have one normal cell, one not. So if you look at those little people, you could see the little red depict that they have that abnormal gene. They both have it. And when they pass down the gene, one little baby can have both of these abnormal gene, which is 1 in 4 chance. 2 out of 4 chance, or half the time, they actually can, one parent could each pass on the gene and they have a child with what we call, again, sickle cell trait. And there is that one other chance, that 1 in 4 chance that they could pass down 2 of their normal gene and that child has nothing, basically has, again, hemoglobin A. So that is how that, from coming from the sickle cell trait, you pass down the gene to the children. And this picture re-emphasize it again, just so you could see that, again, the 1 in 4 chance of having a normal kid when you have two parents with a trait, and the 1 in 4 chance of having a child with the disease, and the half chance or 2/4 chance of having it with the trait. So what are some other types of sickle cell can we talk about? So we talked about sickle cell trait, right? Basically the mom or the dad has a hemoglobin that's normal, which is hemoglobin A, or hemoglobin S, that's a mutated hemoglobin that can cause sickle. And then we have the sickle cell disease, when you have 2 of those hemoglobin affected and they carry 2 of those genes. Now remember, we mentioned some other types of sickle cell. There are other types where, for example, one parent may have the S, the other parent have a hemoglobin C, and they pass that on, and those create these other types of sickle cell. So one thing to remember, if you remember anything this evening, is to know your status, especially if you are really any ancestry, but if you have a Black ancestry, do you know if you have sickle cell trait? And if you don't, you can find out. So you could definitely get your doctor to test you for it, or you could actually go to the health department and get a test for it. And when you have kids, if you do have the trait, just finding out the person you're dating, do they have the trait or not? Or do they have another type of blood disorder or another type of mutation hemoglobin that can cause you to have sickle cell disease? So in the state of Florida, how do we know people have sickle cell disease? So just to remember, every baby who is born in this country usually has what we call a newborn screening. Okay, so when you have a baby, they take a little blood and they do this little card at the bottom where you see those 5 little red dots. Each red dot kind of stand for a certain test that is done to look for blood disorders or other disorders genetically that can be passed down, that are emergencies that we need to know about so that we could educate patients and their children very early on. Currently, 47 states, including Washington, D.C. and Puerto Rico, they provide mandatory universal screening, and Florida is one of those states. These specimens are done as soon as a child is born. And the reason it's done is really because sickle cell disease can cause so much damage in a patient. We want to make sure that that early detection can help us with educating those kids and really giving them the right guidance and providing them the comprehensive care, which will help decrease the morbidity and the mortality that we can see in infancy and in childhood. So newborn screening took a while to get there. So initially, you remember we talked about 1910 being discovered sickle cell. It wasn't until 2006 that we were able to get all of the 50 states and DC to actually do newborn screening. And I do believe Florida was in 1997 that they finally got it together, as I would say. But as you could see, it took us a while to really get to the point of taking care of patients with sickle cell disease, and there is still more to go. So this is another picture that kind of goes over what newborn screening can look like. So when a child is born, if they have what we call a hemoglobinopathy, meaning that there is some kind of a mutation in their hemoglobin, their newborn screen will be positive. And once it is positive, the pediatrician will actually contact the family and will make sure that they're able to see a hematologist that will help them with the diagnosis and help with management. And this slide kind of shows you all of the different kind of labs you can see in newborn screen. And I'm sure you guys are wondering, well, what is F? F is actually stands for fetal hemoglobin. Everyone is born with fetal hemoglobin because that is the first hemoglobin that the body makes when you're a baby. That hemoglobin actually does not stay around long. By age 6 months to 9 months, it goes away. And whatever your body, your genetic tells it to make, it begins to make it. So if you are to make hemoglobin A only, you would start making hemoglobin A only after you're born. And if you have to make hemoglobin S, you would start to make hemoglobin S. And that fetal hemoglobin will slowly go away to allow the body to make the hemoglobin that the gene tells it to make. So that's why there's always an F when we look at a newborn screen result. So when we look at sickle cell disease, and this is a picture, we call them an electronic microscopy picture of the cells. You could see here, again, remember I talked about those little donut cells, nice and pretty little donuts. But when you have that sickle gene, those cells don't always look like donuts. They can look misshapen, especially when they're exposed to different stressors we'll talk about in a little bit. And this is again under the microscope. So if I were to get some blood from someone with sickle cell disease and put it under the microscope, this is potentially what I would see, right? You would see some cells here that still may look like a little bit of donuts, but you'll see some that are sickling that look like that banana shape, and some others that are a little bit destroyed, depending on how stressed they are. And the red represent the red cells, right? That's why they call red cells, because under the microscope they look red. Again, so when we have that normal hemoglobin, we have these red cells, and when we don't, we have these sickle cells that can cause a lot of damage to the tissue of someone with sickle cell disease. So we're gonna kind of talk a little bit about what do we need to do for patients now, right? Once you have sickle cell trait, we talked about a little bit. We reviewed what the cell really looks like and why it caused that. And just remember that that little hemoglobin in the red cell is so important that it causes a cascade of concerns for patients. So when a patient is diagnosed with sickle cell disease, it is quite important that they are seen by a hematologist so they could be managed. So what happens? We've seen what the hemoglobin looks like, right? So this is kind of the pathophysiology of what goes on in the body when it comes to sickle cell disease. So first thing that we can often see is anemia. So what is anemia, right? Anemia is basically because those hemoglobin or those red cells are so fragile and they can get damaged so quickly. When they break down, it's just not enough of them around. So you tend to have a lower hemoglobin, which is why it's called anemia at times. Now, not everyone with sickle cell disease are very anemic. It depends on the type that you have. So the other thing that can happen with the red cell is that the hemoglobin S can do something called polymerization, meaning that it looks like that sickle shape. It could sickle, and all of those sickle cells get stuck within the vessel. When they continue to sickle so much, they end up breaking down because they're so fragile, and they what we call hemolysis, which is the breakdown of the cells. And with all of that, that kind of causes what we call anemia, or the lower hemoglobin in the body. In addition to that, those cells can also cause a lot of damage. So they could cause something called vaso-occlusive crisis, which oftentimes referred to as pain, right? Sickle crisis. They also, in addition, can also have a lot of activation of the cells in the body. So a patient with sickle cell disease really is mostly inflamed. They always have a higher white count, higher platelets, which are the other cells in the body, just because the body is always trying to compete with the inflammation that goes on. That inflammation can cause a lot of damage and concerns as well within the body. So you could see from that one little mutation, we get a cascade of events that can occur. And this slide kind of depicts the same again. So when we have those, what are some of the manifestations we can see in a patient with sickle cell disease? One of the first manifestations we often see in our babies is that little picture at the bottom. That's that little swollen hand and feet, which is referred to as dactylitis. Dactylitis is the first time where those red cells kind of get stuck within the vessels, and you get that swollen hand because there's just not a lot of room for them to go. So you get a lot of blood that kind of stays around, and inflammation. If you know someone with sickle cell, sometimes they may have what we call jaundice, or sometimes I call scleral icterus, meaning the yellowing of the sclera, which is the white part of your eye. And that is often a reflection of those red cells breaking down so much. And the pigment, as it goes away, it could look like a yellow pigment after it breaks down. The picture in the middle kind of looks at gallstones. So patient with sickle cell disease can have a little bit more gallstones because, again, as those pigment break down, they make big pigment stones that as they go to the gallbladder, they're unable to come out, and they kind of form like this in there. This picture down here, and most people may not realize what it is, but that white part is telling us this person had a stroke. It's not supposed to look like that, right? So there is decreased blood flow to that brain because those red cells, again, can get stuck within the vessels, and we have vessels everywhere. So wherever the vessels get red cells stuck, there could be decrease in blood flow, which could cause all of those things we just described. So some of the most common manifestation we talk about with sickle cell disease, pain is very common. However, it's not what's gonna kill someone with sickle cell disease. Usually a bad pneumonia, acute chest syndrome is one that can block so much oxygen to the lungs that can cause damage enough that could cause them problems. Infections are very instrumental in how they could cause problem in patients with sickle cell disease, especially our babies. They could have kidney problems, liver problem. We talked about gallbladder. They could have spleen problems, stroke. They can be anemic. They could have priapism, which is basically decreased blood flow to the penis, which causes an abnormal erection. They could have eye problems, and of course, pregnancy complications as well. So this picture just kind of described pretty much all that I just mentioned, but in one. So one thing to keep in mind is wherever the blood flows and there is a blockage from that blood because of the sickling, you can cause damage to the tissues and to the rest of the body. So how do we deal about this, right? It took us a while, but in 2014, we actually developed some guidelines to really help people manage. And today I'm not gonna really talk a lot of medical, how you're gonna manage, because you guys are not doctors this evening. But I do want you to know, if you have someone in your family who may have sickle cell, some of the things that we think are important, right? So for us doctors, fever is very important. And why is that? Because infection can really cause a lot of damage to patients with sickle cell disease. Again, the spleen. The spleen is one of the most little important organs in the body of a patient with sickle cell disease. Patient with the most common type of sickle cell disease called SS, usually their spleen is not as functional as someone who doesn't have any mutation in their hemoglobin. And the spleen is probably a very important organ because it helps fight infection. So when the kids are small, we often teach the parents to palpate the spleen because the spleen can get big as well. And when it gets big, it causes what we call anemia, more severely in patients with sickle cell. Acute chest, I think I mentioned that earlier. Acute chest is one to be very careful about. Acute chest can look like a pneumonia in a sickle cell patient, but a patient with sickle cell disease cannot spend time in the ER with a pneumonia and not be assessed very quickly, get the right antibiotics, and be taken care of, because we know acute chest is one of the reasons a lot of our patients can die from. And we'll talk a little bit about COVID-19 and why it's important. The lung is probably a very vital organ for patients with sickle cell. We talked about stroke. Stroke can happen. Fortunately, with the care that we give in sickle cell disease, stroke is one of those that we've decreased rate of, because now we're able to actually look in the brain of kids and predict if those kids are high risk or low risk for stroke. And if they are high risk, we actually will start them on medical management very quickly to really make sure that we could catch that. Now, does that mean they will never have strokes? No, it just means that we are able to prevent them if we are able to give them medication. And this picture kind of shows you what happens here. Again, those sickle cells get stuck in the vessels of the brain, and without enough good blood flow to the brain, you can actually get a stroke. And one thing to remember about stroke, you can also have what we call silent stroke, right, with sickle cell patient, because you have a smaller region, it doesn't show a big damage, which is why when kids are young, we start evaluating to making sure, are they functioning right? Are they paying attention in school? Are they able to get help if that happens? Because they can have silent stroke that nobody noticed, because it's again, blood flow blockage. Pain. I often say pain is the most painful thing we discuss in sickle cell disease, because we don't really get the pain, right? We know why it's happening, but we have a hard time controlling pain. As painful pain is, we always have to remind our colleagues in the ED and our colleagues in the hospital that patients that come in with pain need to be treated for their pain to help. So the good news is, yes, there are complications. Yes, there are different things that happen, but we have made some progress. We in 1980s were able to get this medication hydroxyurea, which was approved in 1998 and has really changed the landfill of how we see patients with sickle cell disease. Not everyone responds as well to hydroxyurea, but the majority do. And hydroxyurea definitely has changed the management that we have with sickle cell disease. But in 2017, we actually added some more medication. So one of them was L-glutamine, which is a supplement. We call it Endari. And then later on, 2 years ago, we actually added two other medication, one to help with pain crisis, and one to actually help with the anemia that we see in patients. This is good, but it's not good enough, right? With a disease that we've known at since 1910, we only have 4 medication for this disease. So we need to do more. We need people like you in your community to keep raising awareness, to talk to your senators, to really get people moving, to give us more funding, to really help us get more care for our patients when they have the disease, or your family members or your friends that may have sickle cell. So I'm shifting gear a little bit now to talk about some things that we see, right? The new thing that we focus on right now is COVID-19. COVID-19 affects all of us. But when a patient has sickle cell disease or any immunocompromised disease, the mortality with sickle cell disease is even worse. So we have been very vigilant in recommending that our patients get the vaccine so that they could protect themselves or educate themselves about how to fight for the vaccine. And basically, you know, we are making changes in treatment for sickle cell, but we also now have to deal with COVID and causing damage. The other thing I want to talk to you guys about is donation of blood. So patient with sickle cell disease, sometimes if they become too anemic, they may need blood. So as African Americans of us of Black ancestry, we should definitely move forward in pushing to really get more blood donated to really help save a life if you can with that. And this really concludes my presentation on understanding a little bit about sickle cell trait and sickle cell disease. I welcome any questions if they have any. I think I see some in the chat or some things in the chat.
Dr. Clay, while you are, our guests are getting ready to ask the question, I'll come up with one here. I noticed in your slide there that states most of the southern states are the ones that has most sickle cell diseases. What are the underlying factors that contribute to the southern states? Do you?
Yes, the biggest factor is that's those states have the highest population of people of African ancestry, right? So if you look at the southern area, it reminds you of like the slave trade, right? So where did the slave come from in Africa? They all went to the southern states mostly. So you get to see a lot more of sickle cell in those states because a lot more people pass the gene, right? It's genetic. So it's you know, wherever the Africa went, it will follow. And you'll notice that some of those northwest region are not as much affected because there were not a lot of African Americans in those states. California is a little different because there's a lot of people that comes to California from the southeastern region, from the not southeastern region, I'm sorry, from the Asia, as well as from India, which is why you will see a lot more different variation in the type of sickle cell we see in California because of the location of the state itself.
Thank you.
You're welcome.
Yes. What's the life expectancy of a person with the sickle cell disease?
Very good question. Thank you for that. So the life expectancy of someone with, so there's different types, right? So I'm going to talk about SS. So SS is the most common type of sickle cell we see, and that's when each parent carry the S gene and pass on the 2S. These individuals, the mean life expectancy is now around 45 to 50 years of age. And when I say mean, I mean the average amount of time. We do know that people with SS can live past 60s and their 70s, and that some may die younger as well, depending on how well they take care of themselves. But that has really changed. When I first got into sickle cell over 15 years ago, we used to tell people, oh, you would not make it past 20. So in the last 20 years, we've really changed that landmark where the life expectancy for someone with SS is over 45 to 50 years of age. Obviously, we want this to be higher because that's still 30 years lower compared to the general population. Patient with SC disease and S beta thalassemia plus actually can have a normal life expectancy, especially if they get good care and they follow with a hematologist and they're able to get all of their health maintenance in time. Most of them live normal lives. They may have episodes of pain or they may have some complications, but most of them live normal lives. I hope that answers your question.
When you're diagnosed with sickle cell, they'll tell you SS or ST. They will tell you that.
Yes, they will. So when you get, actually, even in your newborn screen, SC is the easiest one to diagnose because as soon as you're born, it'll say SC and it's pretty easy. SS can be a little complicated because it will say FS, and it could be S, or it could be another type of sickle cell called sickle cell beta thalassemia.
Do we have an idea what create a crisis, that stimulate a crisis?
We do. So some of the things we know that definitely can trigger a crisis can be exposure to stress, whether it's physical stress or mental stress can trigger a crisis. Deoxygenation, so high altitude, if you overexert yourself too much, extenuating exercise, even though we recommend that patients exercise, we often tell them to rest. Dehydration actually can cause a lot of crisis as well. So not enough water, nutrition, air pollution, smoking, all of those have been found to be associated with crisis. I think there is a question in the chat.
Yes, there's a question. Yes. It
Outside
says
of
that-
medical intervention,
ahead.
what lifestyle recommendation can prevent a crisis? Yes, very good question. So yes, so there, outside of medical recommendation, one of the things that often stressed out with patients, hydration is really key. Staying hydrated. I know there's a lot of people out there doing alkaline water, and that we haven't found any difference with alkaline water compared to regular water, but we do know hydration is good. So if you're gonna drink water, I'm happy whether it's alkaline or not. The diet is definitely a key factor. There's a lot of studies currently being done on diet and nutrition in patients with sickle cell disease. One of the things we recommend is a healthy diet. So healthy, not a lot of heavy meats, but like lean meats, vegetables, and good grains, avoiding high salt. Those things have been found to have good impact in patient with sickle cell. And the one thing I would say, the other thing is really living a healthy lifestyle is probably the most important impact, right? And I know just like if we didn't have sickle cell, you have a healthy life, you're gonna live longer, we hope, right? So just, exercising, having that on a daily routine, eating healthy, having good mental health, right? So if you have stressors like depression, anxiety, getting care of those. I often recommend meditation, yoga to my patient because those can actually relieve their stressors that they may have. All of those can help with really helping with a patient. And they're very important. It's not just medical intervention. I have patients that's really what they do, and they do really well. And we don't always have to give you medications if you are able to manage your sickle cell with those other interventions.
So a person that has SS and a person with ST should never marry?
So I wouldn't say you should never marry because trust me, they all find each other somehow. But I would say you should be cautious because you can have that 25% chance of having a child with the disease. I think if you know your status and you could ask your partner, and I think I've had people ask me, well, I shouldn't marry somebody who's Black. No, because somebody who's white can have another hemoglobinopathy. Somebody who's Hispanic may have another hemoglobinopathy. Somebody who's Asian can also have maybe thalassemia or hemoglobin E. So you could still have sickle cell disease with other races. You just have to know what their status is, regardless of what they look like, their skin color looks like. Because remember, it's genetic. You can't look at someone and decide if they have trait or sickle cell or any of that, right? It's genetic. So I wouldn't say they shouldn't marry. I think we would counsel them and we would let them know that you have the chance of having a child with sickle cell disease.
All right.
Question for you, Dr. Clay.
Yes.
So you encourage to give blood. Can
Yes.
someone with high cholesterol, will they take blood from you if you have high cholesterol?
Yes, they will. They don't check your cholesterol when you give blood. One thing they will check is make sure you're not anemic. So we usually have a blood bank, a blood truck. One blood is who gives blood. I think they come every Tuesday in front of our hospital. So, or anywhere, if you could call them and find out where they at. I don't believe they're gonna check you for cholesterol, but they will check you for other diseases, right? Because we don't want to give a blood that may have infection in there to give to patients. So they may check for certain diseases to make sure you don't have those. And if you're not anemic, right? Because if you don't have enough blood yourself, you shouldn't be giving blood. So like I can't give blood because I have a blood disorder. So I love to go, I would love to give blood, but I can't. But I am registered to donate my marrow if one day somebody matches. So that's the thing I was able to do.
And that was the other thing I was gonna ask. At what age should you stop giving?
Blood donation greater than 18.
Okay. All right. Any other questions for Dr. Clay this evening?
One other question would be, so a person who wants to get married, that should be their first question. Are you ST or SS? That should be the first question instead of saying, I love you, something like that.
Right. Good question. So actually, when I teach my teenagers, when they start dating, so that is what I tell them. I said it should be, hey, what's your name? Where you from? Do you have any blood disorder in your family, right? Because I mean, it's part of it, right? Just like you want to know. And the good thing is, you know, because now we have newborn screen, most people would know if they've had the trait. And oftentimes, you know, parents are told about that. So I tend to see more patients that are a little bit older that may not have known at all. But most of our younger people, they know they have the trait. Oftentimes, so the people that don't rarely know are the men. So I encourage the men to know your status. So the women, they know because once they're pregnant, somebody tests them to see if they have the trait. But the young men or the men, oftentimes they don't know if they had the trait, and then we happen to find it when the kids are born with the disease. So yes, that is a good question I would ask, right? Because you kind of want to know, you know, what you're getting yourself into. Obviously, if you fall in love, regardless, it shouldn't matter because, you know, it is what it is. We still would take care of that child, and they could have a normal life depending on what kind of sickle cell they have.
All right. We can take one more question if there's one. Is there another? All right. There's none.
Can I just add one more thing?
Yes,
I do want
Dr.
to
Clay.
add that, yes, even if you had a child with sickle cell and you found someone and you did, remember their children that were born, and we will take care of them as hematologists, because we see kids that are born all the time that may not have a genetic disorder, but they can have something else, right? So sickle cell disease is not a death sentence. It's just a disorder, just like diabetes, asthma, or something else, right? So it is something that we've learned enough that I don't want you all to think, well, I'm just never going to talk to anybody who have the trait. If it so happened that someone you fall in love, you have a kid, they will be taken care of by a great hematologist in this country.
This evening, it is my privilege to give the vote of thanks to our presenter this evening, Dr. Clay. We just want to say thank you very much for taking the time out of your busy schedule. I'm quite aware of what a doctor time schedule can be. I have one in my house as well, so I'm aware what it is. But thank you very much for putting this presentation together and presenting it to us in such an informative way, such an educated way, such a simple way. What I'm saying, you have put it together in a way that everyone that were listening in could take something from this presentation. The questions that came in seem to indicate to me that you stimulated the thoughts and imagination of the listeners. And so again, thank you very much for coming and presenting to us. The person who gave the introduction, I also want to thank her for introducing you. giving us a taste as to what we were about to receive. It is my desire that God will continue to bless you in your work, in your field of work, in your ministry, and that as you work in that area and attend to individuals with these diseases, that we will get better health. And because health is all about what we should be, God is very much interested in our health. So again, thank